Welcome to a deep dive into the absolute marvel that is human gastrointestinal embryology. We're so glad you are here with us.
Yeah, glad to have you.
Whether you are prepping for a medical board exam, trying to understand a diagnosis, or just insanely curious about how you were built from scratch, this is for you.
There's so much to uncover.
There is. We've got a fascinating stack of sources to go through today. It features a comprehensive GI embryology master guide and a really rigorous set of clinical reasoning questions.
Really great material.
Our mission today is to trace the journey of how your digestive system constructed itself and how the echoes of that ancient microscopic construction project are still dictating your health right now.
It's a journey, for sure.
Okay, let's unpack this. We have the single tube. Picture a basic cylinder. How on earth does a single tube turn into a respiratory system and a highly segmented digestive system?
Well, to conceptualize that, you have to understand the map the embryo uses to build the gut in the first place.
Right.
And that map, fascinatingly, is drawn in blood.
Oh, wow.
Yeah, before we even talk about stomach tissue or liver tissue, we have to look at the three-part arterial roadmap that dictates absolutely everything.
Okay.
The primitive gut tube is divided into three distinct regions: the foregut, the midgut, and the hindgut.
And these aren't just like arbitrary zones we made up for textbooks, right?
No, not at all. They are strictly defined in vivo by their blood supply.
So blood vessels are essentially planting flags in this early tissue, claiming territory long before the organs actually take shape.
Precisely. The embryo lays down three massive arterial branches off the primitive aorta.
Got it.
The top section, the foregut, is supplied by the celiac trunk.
Okay, celiac.
The middle section, the midgut, is supplied by the superior mesenteric artery, or SMA. And the bottom section, the hindgut, is supplied by the inferior mesenteric artery, the IMA.
So foregut is celiac, midgut is SMA, hindgut is IMA.
Exactly. If you are taking notes right now and you remember nothing else from this first section, remember that foundational rule. Celiac equals foregut, SMA equals midgut, and IMA equals hindgut.
The sources hammer that rule home repeatedly because it really is the Rosetta Stone for GI anatomy.
It absolutely is.
So let's rewind the clock just a little bit to see how you and I even got this tube in the first place.
Right. Let's go back.
The texts point us to week 3 and week 4 of human development. Let's break down the timeline. Week 3 is dominated by a process called gastrulation.
Yeah, gastrulation is the defining moment of early embryology.
Why is that?
Well, before week 3, the embryo is essentially just a flat, two-layered disc of cells.
It's like a pancake.
Pretty much. But during gastrulation, cells start migrating inward, creating a three-dimensional, three-layered structure.
Okay, so it gets depth.
Exactly. These are the three foundational germ layers: the ectoderm on the outside, the mesoderm in the middle, and the endoderm on the inside.
And just broadly speaking, ectoderm becomes things like skin and brain, mesoderm becomes muscle and bone, and the endoderm becomes the internal linings, right?
That is the broad stroke, yes.
Okay.
For our purposes today, with the GI tract, the definitive endoderm becomes the epithelial precursor of the gut. It is the innermost lining.
Gotcha.
Then, in week 4, a massive structural shift happens. The embryo undergoes folding.
So it stops being flat.
Right. Imagine taking that flat pancake and folding it simultaneously head to tail, which is craniocaudal folding, and side to side, which is lateral folding.
So it goes from being a flat disc to a more cylindrical shape. It pinches closed.
And as it folds and pinches closed, it traps and incorporates a portion of the yolk sac into the embryo itself.
Oh, interesting.
Yeah, that incorporated portion, which is lined entirely with endoderm, is what creates the primitive gut tube.
Okay, so that's the tube.
Yes. It becomes a continuous hollow tube running from the cranial end, the future mouth, down to the caudal end, the future anus.
Now, reading through the master guide, I noticed a huge conceptual trap here.
Oh.
Yeah, if the endoderm forms the lining of this tube, it's very easy to assume the entire GI tract is just made of endoderm.
Oh, right. Very common misconception.
Because a gut made only of lining wouldn't be able to actually digest food, absorb nutrients, or physically push anything forward.
It would just be a static, useless tunnel. The GI tract is not 100% endoderm.
So what else is there?
The gut wall is a highly complex composite of multiple embryologic components. The endoderm forms the epithelial lining and the glandular epithelial components, so those cells that will secrete acid or enzymes. But it is surrounded by a very specific layer of mesoderm called the splanchnic lateral plate mesoderm.
Okay, let's demystify that jargon for a second. Splanchnic lateral plate mesoderm.
It's a mouthful.
It is. So splanchnic just means referring to the viscera or internal organs.
Correct.
But what is this tissue actually bringing to the party? I mean, if I'm visualizing the endoderm as the interior wallpaper of a house, what is the splanchnic mesoderm?
The splanchnic mesoderm is the 2x4s, the plumbing, and the foundation.
Oh, I like that.
Yeah, it brings everything that gives the tube structure and movement. This mesodermal layer condenses around the endodermal tube and forms the connective tissue, the smooth muscle layers that will eventually perform peristalsis, the structural supporting tissues, and the vast vascular network wrapping around it.
Wow.
So the endoderm is the lining, but the mesoderm is the muscle and the blood vessels.
That is a brilliant division of labor. You have the chemical factory on the inside and the mechanical engine on the outside. But even with those two, we're missing something crucial. I mean, you can have a tube lined with functioning glands wrapped in strong, smooth muscle, but if that muscle doesn't know when to contract or relax, it's just a dead hose.
Right. It needs a command center. It needs nerves.
Which brings us to our third major cellular player.
The neural crest cells.
Tell us about those.
They are a fascinating population of cells that originate way up near the developing neural tube, the future spinal cord.
So they start way up high.
Yes, and they undergo an incredible long-distance migration down into the gut wall to form the enteric nervous system.
The gut's own brain.
Exactly. Specifically, they form the myenteric plexus, also known as the Auerbach plexus, and the submucosal plexus, known as the Meissner-plexus.
The analogy that immediately jumped to mind when I was reading this part of the source material was construction.
Let's hear it.
So, wait, if the mesoderm forms the muscle walls and the endoderm forms the interior drywall, the neural crest cells are basically like electricians coming in after the drywall is up to lay down the wiring.
I love that analogy because it captures the active nature of their journey. The electricians have to travel a massive distance to wire the entire house, from the esophagus all the way down to the rectum.
A long commute.
And they don't just lay random wires, they're laying the autonomic nervous system's specific routing.
Right. Let's talk about that autonomic wiring. Because the source points out a very specific divide in how the parasympathetic nervous system, the rest and digest system, connects to our three arterial territories.
It does.
The foregut and the midgut get their parasympathetic signals from the vagus nerve.
The vagus nerve is cranial nerve 10. It wanders all the way down from the brainstem through the chest and supplies parasympathetic innervation to the esophagus, stomach, liver, and the entirety of the small intestine and early large intestine.
So it's covering a ton of ground.
It is a massive superhighway of autonomic control.
But the vagus nerve doesn't reach all the way to the end. The hindgut territory has a completely different power source.
It does. Once you hit the hindgut, which is the distal part of the transverse colon down to the rectum, the vagus nerve taps out.
Okay, so what takes over?
The parasympathetic innervation for the hindgut comes from the pelvic splanchnic nerves, specifically originating from spinal cord levels S2, S3, and S4.
That is such a critical map to hold in your head.
It really is.
Foregut and midgut equal vagus nerve. Hindgut equals pelvic splanchnic.
Yes.
And all of this wiring is being laid down by those migrating neural crest electricians. It proves that the gut isn't just one tissue, it's a composite of different origins.
And this composite nature isn't just anatomy trivia for a textbook. It represents a deeply dynamic process called epithelial mesenchymal interaction.
Sounds intense.
Well, throughout this entire developmental window, the endoderm and the mesoderm are constantly communicating.
Like chemically.
Yes, the endodermal lining doesn't just passively sit there. It secretes chemical signals that diffuse into the mesoderm, telling it how to differentiate. Simultaneously, the mesenchyme secretes signals back to tell the endoderm what specific type of lining to become. They are locked in a continuous molecular dialogue.
I find it so compelling that these tissue layers are constantly talking to each other to figure out what organ they are supposed to build. It's not a top-down command, it's a cellular negotiation.
A very fragile negotiation.
Yeah. So what happens when that negotiation fails? Or when those neural crest electricians fail at their job?
That's where things get dangerous.
The clinical Q-Bank in our sources has a gripping case study about this exact wiring issue in an adult patient.
The case of achalasia. This is a perfect illustration of why the enteric nervous system is non-negotiable for human survival.
So the vignette introduces us to a 46-year-old woman. She's been experiencing progressive dysphagia, meaning difficulty swallowing, for 2 years.
Right.
But here is the crucial clinical clue. It's dysphagia to both solids and liquids right from the very beginning of her symptoms.
That's the key. Plus, she's regurgitating undigested food at night when she lies down. So they do a barium swallow, where she drinks a thick, chalky contrast liquid while they take real-time x-rays.
And what do they see?
It shows her esophagus is massively dilated, but it tapers to a smooth, narrow point at the very bottom, right before the stomach.
Radiologists call that the classic bird beak appearance.
Oh, because it comes to a point.
Exactly. When a patient presents to a clinic with difficulty swallowing solids and liquids simultaneously from the onset, it fundamentally alters your diagnostic pathway.
How so?
It almost always points to a motility disorder, a functional electrical problem, rather than a mechanical obstruction. If she had an esophageal tumor, for instance, it would block solid food first. She'd be able to drink water fine until the tumor grew much larger.
Because liquids can just sneak around the tumor.
Right. But struggling with liquids immediately implies the muscle itself has lost its coordination. Our source text zeroes in on the cellular abnormality driving this nightmare. It's a loss of enteric inhibitory neurons containing nitric oxide. Let's break down the pathophysiology there.
Sure. Achalasia is an acquired degenerative loss of those specific neural crest-derived electricians in the myenteric or Auerbach plexus.
Okay, so the wiring is dying.
Yes. In a healthy esophagus, when you swallow, these inhibitory neurons release nitric oxide and vasoactive intestinal peptide.
And what does the nitric oxide do?
Nitric oxide is a potent, smooth muscle relaxant. Its entire job is to tell the lower esophageal sphincter to relax and open up so the bolus of food can drop into the stomach.
So if those specific neurons degenerate and die off, the muscle loses its relax signal.
Exactly.
Without the nitric oxide telling the muscle to chill out, the lower esophageal sphincter is essentially clenched shut permanently.
It remains in a state of high resting tone. The sphincter simply fails to relax. Furthermore, because the myenteric plexus is damaged, normal coordinated peristalsis in the body of the esophagus is also lost. The smooth muscle contractions become chaotic or absent.
So the food just sits there.
It just sits there. Over months and years, the backing up of food and liquid physically stretches and dilates the esophagus above the blockage, creating that massive megasophagus you see on the barium swallow.
It's a prime example of why the neural crest contribution to the gut is just as vital as the endoderm or mesoderm. The structure is entirely intact, but the wiring is dead, rendering the organ useless.
It beautifully proves that you need all three layers working in perfect harmony.
We need the endoderm lining, the mesoderm muscle, and the neural crest wiring.
Correct.
Now that we have our single tube established, and we know our three blood vessels, celiac, SMA, and IMA, let's zoom in on the top section, the foregut, because this is where the anatomy gets incredibly crowded and the developmental stakes get remarkably high.
Crowded is an understatement.
It's busy up there.
The foregut territory extends from the pharynx in your throat all the way down to the proximal duodenum, ending roughly at the major duodenal papilla, which is where the bile duct empties into the intestines.
Right down the boundaries.
Its main artery, as we established, is the celiac trunk. But it doesn't just form a straight tube of esophagus, stomach, and early duodenum. It undergoes massive budding.
Right. The sources detail how the foregut literally buds outward to form your major accessory organs.
Exactly.
The liver, the gallbladder, the entire biliary tree, and the pancreas, they all arise as endodermal epithelial buds sprouting out from the ventral wall, the front wall, of this primitive foregut tube.
They push outward into the surrounding mesoderm, utilizing that same epithelial mesenchymal dialogue we discussed earlier to grow into massive solid organs.
But even more dramatic than the liver or the pancreas is what happens to the respiratory system.
Oh, this is wild.
I have to admit, this is a part of the source material that completely broke my brain. Because when you look at an adult, the lungs and the stomach seem functionally and anatomically worlds apart. One breathes air, one digests food. But embryologically, the lungs and the trachea are foregut derivatives.
They absolutely are. Around week 4 of development, a respiratory diverticulum, often called a lung bud, starts to grow directly out of the ventral wall of the foregut.
That's so strange to think about.
It is. So for a brief window of time, your entire respiratory tract and your upper GI tract are one shared, continuous tube.
If I'm trying to visualize this, it's like trying to take a single flowing water pipe and split it down the middle into a gas line and a water line. If that central dividing wall isn't built perfectly, you have a disaster.
The engineering tolerance for error is essentially zero.
Right.
The embryo has to build a physical wall called the tracheoesophageal septum to separate the ventral respiratory tract, the trachea in the front, from the dorsal esophagus in the back.
And this brings us right back to the molecular biology of the embryo. This physical separation, this building of a wall, is driven by an intense genetic tug of war.
It really is a tug of war.
The sources dive incredibly deep into the specific transcription factors and genes orchestrating this. Let's explore the genetics, starting with retinoic acid and the Hox genes.
Okay, so before cells can split into lungs or stomach, they first need to know where they are located in the body.
Makes sense.
Retinoic acid, which is a derivative of vitamin A, diffuses through the embryo to provide positional information along the anterior-posterior axis.
So it's like a GPS.
It acts exactly as a biological GPS coordinate system. A certain concentration of retinoic acid tells a group of cells, you are located in the cranial region, therefore your broad identity is foregut.
Got it.
This positional signal regulates the expression of Hox genes, which lock in that regional identity.
Okay, so the retinoic acid GPS tells the tissue it's the foregut. But once it knows it's the foregut, it has to make a much more specific decision. It has to decide dorsal versus ventral, front versus back, trachea versus esophagus.
What's fascinating here is that the primitive endodermal cells that will eventually become your delicate lung alveoli and the cells that will become the harsh acid-secreting lining of your stomach start out with identical potential.
They're exactly the same at first.
They're the exact same tissue. They remain identical until a molecular gradient forces them to choose a side.
Wow.
The cells on the dorsal side, the back of the foregut tube, begin to express high levels of a transcription factor called SOX2. SOX2 is the master regulator for esophageal and gastric identity.
The source guide actually includes a great mnemonic for medical students.
Oh.
SOX2 stays esophagus.
It is a bit silly, but in the stress of a board exam, it works perfectly.
Whatever works.
Exactly. SOX2 drives the dorsal pathway. Meanwhile, the cells on the ventral side, the front of the tube, begin to express high levels of a completely different transcription factor called NKX2.1.
And that one builds the airway.
Yes.
Yeah.
This is the master regulator for respiratory identity. NKX2.1 is the architect that builds the airway.
I picture this like two rival architects fighting over a single blueprint.
That's a good way to look at it.
You have SOX2 in the back shouting, I'm building an esophagus, bring me stratified squamous tissue. And NKX2.1 in the front shouting, I'm building a trachea, bring me ciliated cartilage.
Pretty much.
But shouting at each other doesn't build a wall. How do these molecular architects physically split the tube apart?
The physical construction of the dividing wall is driven by a signaling pathway that is famous in embryology. The sonic hedgehog, or SHH. pathway.
I love that biologists actually got to name a critical gene after the Sega Genesis video game character in the 90s.
Right. And we just have to live with it forever in serious medical literature.
I think it's fantastic.
Yeah.
How does sonic hedgehog actually work here?
It operates like a complex molecular relay race. The endodermal lining of the gut secretes the sonic hedgehog protein ligand.
Okay.
This protein diffuses outward and acts as a signal to the surrounding mesenchyme, R2x4s, and plumbing.
So it's talking to the muscle layer.
Yes. The mesenchymal cells receive this SHH signal through a pair of receptors on their surface called PTCH1 and SMO.
So the endoderm lining shouts sonic hedgehog, and the mesoderm muscle layer hears it with its PTCH1 and SMO antennas.
Exactly.
What happens inside the mesoderm cell once it receives that signal?
When SMO is activated, it triggers a cascade inside the cell that activates a family of transcription factors called GLI.
Okay, GLI.
GLI then travels into the nucleus of the mesoderm cell and turns on a multitude of target genes.
And the source mentions GLI triggers a specific factor called FOXF1.
Yes, FOXF1 is critical. The activation of GLI and FOXF1 in the mesenchyme coordinates the release of other powerful signaling molecules, specifically BMP and WNT.
There are so many acronyms, but I'm following. So what do BMP and WNT do?
Now, this is where the loop closes. These BMP and WNT signals feed back to the endoderm epithelium to reinforce that SOX2 and NKX2.1 balance.
Oh.
But critically, they also drive the mesenchymal cells themselves to proliferate rapidly. The mesoderm condenses, multiplies, and physically forms a wedge of connective tissue and smooth muscle that pushes between the dorsal and ventral endoderm.
Oh, wow. So it literally grows a wedge of muscle to zip up the middle of the tube, separating the trachea in the front from the esophagus in the back.
It literally zips it up.
It is a stunningly fragile relay race of molecules. And when that zipper fails, when one transcription factor misfires, the results in a newborn are catastrophic.
When this highly choreographed developmental program fails, the result is esophageal atresia with a tracheoesophageal fistula, commonly abbreviated as ETEF.
Put us in the neonatal intensive care unit. How does that structural failure actually present in a brand new patient? What happens to a baby if this tube didn't split correctly?
It is an immediate life-threatening crisis in the delivery room.
I can imagine.
The most common anatomical variant of ETEF, making up about 85% of cases, is when the proximal esophagus ends in a blind pouch, and the distal esophagus is connected via a fistula directly to the trachea.
Oh no. So when a newborn with this anatomy attempts their very first feed, whether breast milk or formula, the fluid goes down the esophagus but hits that blind pouch.
Yes, it has nowhere to go.
It's like pouring water down a blocked sink.
Exactly. The fluid rapidly spills back over the top and gets aspirated directly into the trachea and down into the lungs.
That's awful.
The baby will typically start choking uncontrollably, drooling copious amounts of fine, frothy bubbles, and turning cyanotic, turning blue, because their airway is instantly compromised by the fluid.
That is terrifying for the parents and the medical team.
That's really terrifying.
And our QBank source mentions a classic diagnostic clue that confirms the diagnosis before you even get an X-ray. If a nurse or doctor suspects this and tries to pass a nasogastric tube, an NG tube, down the baby's nose to clear the stomach, they encounter a physical roadblock.
Right. The NG tube goes down a few centimeters and then simply stops.
Just hits a wall.
When they take an X-ray to see where the tube is, they see it coiled up in the upper chest. It can't reach the stomach because the esophagus simply doesn't exist past that upper blind pouch.
And the sources highlight another key radiologic finding: the presence of a massive amount of gas in the baby's stomach and intestines.
Yeah.
Which seems counterintuitive if the esophagus is blocked.
Yeah.
How does air get into the stomach?
This is where understanding the exact anatomy of the fistula is crucial. Because the distal esophagus, the part connected to the stomach, is abnormally tethered to the trachea.
Right.
So every time the baby cries or takes a breath, air from the lungs is forced down through that fistula directly into the GI tract.
Oh.
The stomach rapidly inflates with air, which can actually elevate the diaphragm and make it even harder for the baby to breathe. ETEF is a perfect, albeit tragic, example of how a microscopic failure in early SHH signaling translates directly into gross surgical anatomical defects.
The Forget's identity crisis is clearly a high-stakes game in the embryo. But reading through the clinical vignettes, I noticed this section of the tube remains a trouble spot even in adults.
It really does.
The tissues never truly forget their alternative identities. If you put them under enough stress, they will try to change their programming.
Adult foregut pathologies often have deep roots in cellular identity. Take the distal esophagus, for example. The QBank presents a 58-year-old man with a long-standing history of severe acid reflux who undergoes a routine endoscopy.
Okay, pretty common scenario.
The gastroenterologist looks through the scope and sees salmon-colored, velvet-like mucosa creeping up into the esophagus from the gastroesophageal junction.
That salmon color is the classic hallmark of Barrett esophagus.
It is. To understand why this happens, look at the normal histology. Normal esophageal lining is stratified squamous epithelium.
Okay.
If you picture it, squamous cells are like flat, tough floor tiles stacked on top of each other. They are built for friction, designed to handle rough food sliding down without tearing.
Makes sense.
But the stomach lining below it is simple columnar epithelium. Columnar cells are like deep chemical vats built to secrete massive amounts of acid and mucus, and they are highly resistant to chemical burns.
So when a patient has chronic reflux and stomach acid constantly splashes up into the lower esophagus, those flat squamous floor tiles are getting chemically burned day after day.
Exactly. They cannot survive that environment. So, under chronic acidic stress, the esophageal stem cells reprogram themselves.
They just switch.
Yeah, the esophagus tries to adapt to survive. It literally changes its lining from the tough squamous tissue to an intestinal-type columnar epithelium, complete with mucus-secreting goblet cells.
It's basically the tissue throwing its hands up and saying, look, if you're going to treat me like a stomach and drown me in acid, I'm going to turn into a stomach to protect myself.
That process is called metaplasia, the conversion of one mature cell type to another mature cell type.
It works. Right.
In the short term, it works. The new columnar cells withstand the acid better, but this evolutionary adaptation comes with a severe long-term cost.
Cancer risk.
Exactly. Barrett esophagus drastically increases the genetic instability of the tissue, raising the risk of dysplasia, which is disordered, precancerous growth, and dysplasia can rapidly progress to esophageal adenocarcinoma.
Which is a crucial distinction for board exams. Squamous cell carcinoma of the esophagus is traditionally linked to things that cause friction or direct cellular toxicity, like smoking and heavy alcohol use.
Right.
But adenocarcinoma in the lower third of the esophagus is driven almost entirely by this acid-induced metaplasia.
Correct.
It's wild how the tissue can just revert and change its foundational identity like that. And then, moving just right below the stomach, still firmly in foregut territory, we have the duodenum.
Specifically, the proximal duodenum, which ends right at the major duodenal papilla.
Right.
This entire region is supplied by branches of the celiac trunk. The clinical Q-bank gives us a harrowing vignette. A 51-year-old man who presents to the emergency department with severe hematemesis vomiting bright red blood.
Oh boy.
And melena, which are black, tarry, foul-smelling stools indicative of digested upper GI blood. An emergency endoscopy finds a deeply bleeding ulcer on the posterior wall of the first part of the duodenum.
And the key anatomical question the source poses here is, which specific artery is this ulcer eroding into?
The gastroduodenal artery. This is an incredibly high-yield anatomical relationship for anyone in the medical field to visualize.
So it's sitting right behind it.
Yes. The gastroduodenal artery runs directly behind the posterior wall of the first part of the duodenum.
Okay.
As a peptic ulcer burns deeper and deeper through the mucosal and muscular layers of the posterior wall, it eventually breaches the adventitia and erodes directly into the wall of that major artery.
Which causes massive bleeding.
Massive, potentially fatal arterial hemorrhage.
The sources make a sharp distinction between posterior and anterior ulcers here.
It's a vital distinction. Posterior duodenal ulcers bleed because they erode into the gastroduodenal artery.
Okay, what about anterior?
Anterior duodenal ulcers, on the other hand, sit on the front wall. There is no major artery immediately in front of them.
Right.
So as an anterior ulcer burns through the tissue, it tends to perforate completely through the wall, spilling highly acidic bowel contents and air freely into the peritoneal cavity of the abdomen.
Causing peritonitis.
Yes, peritonitis.
So the clinical rule of thumb is posterior equals bleeding. Anterior equals perforation.
That's a good way to remember it.
And let's tie this back to our initial map. That bleeding gastroduodenal artery is a branch of the common hepatic artery, which traces right back to the celiac trunk.
Right.
So despite being in the intestines, we are still firmly in foregut territory, dictated by that exact blood supply.
The arterial roadmap never lies.
Okay, so the foregut is dealing with this massive, complex identity crisis, constantly trying to figure out if it's a respiratory tube or a digestive tube, and fighting off chemical burns in adulthood.
It's got a lot going on.
But as we move down the blueprint to the next section, the midgut, the nature of the developmental problem, changes entirely. The midgut isn't having an identity crisis. The midgut is having a severe physics-based space crisis.
That is the perfect way to frame it, a space crisis.
Let's lay it out.
Let's define the territory first. The midgut extends from the distal half of the duodenum, past the papilla, all the way through the jejunum, the ileum, the cecum, the ascending colon, and it stops at the proximal 2/3 of the transverse colon.
That is a massive amount of bowel.
It is huge.
Right.
And its entire arterial supply, its single lifeline, is the superior mesenteric artery, or SMA.
According to the timeline in the sources, around week 6 of development, things go completely crazy.
Yeah, they do.
The midgut starts elongating incredibly fast. It's growing like a weed. But the embryo's tiny abdominal cavity just isn't expanding fast enough to contain all this new tissue.
The math of the volume just doesn't work. And to make matters worse, it's not just the bowel taking up space.
What else is there?
Remember that the liver budded off the foregut earlier?
Oh, right.
During weeks 6 through 10, the embryonic liver is growing massively. It is the primary site of hematopoiesis blood formation for the fetus at this stage.
So the liver is hogging all the room.
Exactly. The liver becomes so enormous that it takes up almost all the available room in the upper abdomen. The rapidly elongating loops of the midgut literally run out of physical space inside the embryo's body.
Here's where it gets really interesting. Because the midgut's biological solution to this lack of internal space is to just pack up and leave. It physically exits the body cavity.
It's an astonishing mechanism. It undergoes what embryologists call physiologic herniation.
Okay, break that down.
The rapidly elongating primary intestinal loop is forcefully pushed out of the abdominal cavity and into the extraembryonic column.
Let's clarify extraembryonic column so we can visualize this. It sounds like a void in space.
It essentially is a space outside the embryo proper. The extraembryonic column is a cavity encased within the protective stalk of the umbilical cord.
Wow.
So this is an entirely normal, required phase of human development. If you were to look at an ultrasound of an embryo at week 8, you would clearly see its intestines sitting outside of its abdomen, bundled up inside the base of the umbilical cord.
It is so bizarre to conceptualize that you, me, and everyone listening spend a few weeks of our early existence with our intestines hanging out inside our umbilical cords.
It really is wild to think about.
But they don't just sit there passively waiting to go back in. The sources spend a lot of time on the biomechanics of what happens next. They have to twist. This is the famous midgut rotation.
The rotation is perhaps the most critical mechanical event in GI development.
How does it work?
The herniated midgut forms a primary intestinal loop shaped almost like a hairpin, and it uses its blood supply, the superior mesenteric artery, as its central axis.
Okay.
Think of the SMA as a solid pole sticking straight out of the embryo's back, and the bowel is draped over it.
And the Embryology Master Guide has a very specific rule for how it spins around this pole, the 270-degree rule.
If you are studying for medical boards, this is one of the most heavily tested concepts in all of embryology.
Gotta know the math.
Yep. The midgut must rotate a total of 270 degrees counterclockwise around the SMA axis, and it happens in 2 distinct phases.
Okay, phase 1.
Phase 1 occurs while the gut is actively herniating out into the umbilical cord. As it pushes out, it rotates 90 degrees counterclockwise.
So it's outside the body, twisted 90 degrees. What is it waiting for?
It is waiting for the real estate market in the abdomen to improve. By around week 10 or 11, the embryo has grown, the abdominal cavity has finally expanded enough to accommodate the intestines, and the massive rapid growth rate of the liver has plateaued.
So the space crisis is resolving.
Right. So the bowel begins its journey back into the abdomen. As it physically retracts and returns, it rotates an additional 180 degrees counterclockwise.
So 90 degrees counterclockwise on the way out, plus 180 degrees counterclockwise on the way back in. A total of 270 degrees counterclockwise.
That's the math.
I was trying to picture this, and it's remarkably similar to packing a wildly overstuffed suitcase for a long trip.
I like that.
Yeah, you have too much stuff, so you have to pull all the clothes out of the suitcase onto the bed. You fold them in a very specific twisting origami pattern, interlocking the sleeves and pants. And then you shove it all back in at a precise angle so the zipper finally closes. And if you don't fold it perfectly, the zipper breaks and nothing fits.
The origami suitcase analogy is excellent because the precision is exactly the point. That specific 270-degree rotation isn't just for show.
It has a purpose.
It is the exact mechanical movement required to place all of your abdominal organs in their final correct anatomical positions.
So it puts things where they belong.
Exactly. The spin ensures that the bulk of the small intestine is nestled centrally. And critically, it takes the cecum, the bulky beginning of the large intestine where the appendix sits, and swings it all the way across the abdomen and down into the right lower quadrant.
So what happens if the folding pattern is wrong?
If it's wrong by even 90 degrees, the entire architecture of the gut is dangerously unstable.
And with the SMA acting as the central pole for all this chaotic twisting, I can imagine that if things twist incorrectly or spin too far, that critical artery is in a very vulnerable position.
Exceptionally vulnerable. And this precise vulnerability brings us to a terrifying clinical correlation from the Q-bank, malrotation and volvulus.
The vignette for this is the stuff of a pediatric surgeon's nightmares.
It really is.
It's a newborn infant, entirely healthy at delivery, suddenly develops bilious vomiting shortly after birth. They rush the baby to imaging, and an upper GI series shows abnormal positioning of the small bowel and the cecum.
Let's break down the clinical presentation first.
Sure.
When a newborn has bilious vomiting, meaning vomit that contains bright green bile, it is an ominous sign.
Why is this so bad?
It implies there is a physical obstruction somewhere distal to the major duodenal papilla where the bile ducts empty.
Oh, why?
The bile is flowing into the intestine, hitting a roadblock, and backing up into the stomach to be vomited out. In this case, the imaging confirms the roadblock is caused by intestinal malrotation.
Meaning the spin didn't finish.
Exactly. The fetal gut simply failed to complete its full 270-degree counterclockwise rotation when it returned to the abdomen.
If you're visualizing the anatomy, what physically happens when it doesn't finish the spin? Where do things end up?
If the rotation stalls, the cecum might end up trapped in the upper mid-abdomen, right near the liver, instead of completing its journey down to the right lower quadrant.
That's bad.
It has a devastating cascading effect on the mesentery.
Okay, remind us what the mesentery is.
The mesentery is the broad, fan-like sheet of tissue that anchors the entire length of the small intestines to the back wall of the abdomen.
Okay, like a fan.
Right. It normally has a very wide, stable attachment base, but in malrotation, because the start and end points of the bowel are too close together, the mesentery ends up having a very narrow base.
So instead of the intestines being anchored by a wide, stable fan, they are hanging off a narrow, flimsy stalk.
Exactly. And hanging off a narrow stalk means the entire mass of the small bowel is highly mobile and prone to twisting around that stalk, like a tetherball wrapping around a pole.
That sounds disastrous.
It is. This twisting event is called a volvulus. When the bowel twists upon itself, it physically kinks and chokes off its own blood supply, which, remember, is the superior mesenteric artery running right through the center of that stalk.
It essentially strangles itself.
It causes catastrophic ischemia. The blood flow stops, the oxygen drops, and the tissue of the entire midgut begins to die, undergoing necrosis within hours.
Wow. So they have to act fast.
A midgut volvulus is an absolute drop-everything surgical emergency. If the surgeon doesn't untwist the bowel immediately, the infant will lose their entire small intestine, which is incompatible with normal life.
So when a clinical exam, like the USMLE, tests this concept, what is the trap they were trying to set for the student?
Oh, the trap is always the details of the embryologic spin.
They try to confuse you.
Definitely. They will present a clear case of malrotation and volvulus, and the question will ask for the underlying embryologic failure. The multiple choice options will try to trick you with the direction, the degrees, or the artery.
Like saying clockwise instead of counterclockwise.
Exactly. They will offer plausible sounding choices like failure of 180-degree clockwise rotation around the IMA or failure of 270-degree clockwise rotation around the celiac trunk.
But the real answer is...
You must have the complete accurate phrase locked in your memory. Midgut equals SMA equals 273 counterclockwise rotation. Anything else is wrong.
That is fantastic advice. Lock it in. Midgut SMA 270 counterclockwise.
Yep.
But malrotation isn't the only thing that can go wrong with this wild herniation process. What if the gut just never goes back into the suitcase at all? What if it stays out in the umbilical cord?
If the physiologic herniation never reverses, you have a congenital defect called an omphalocele. The baby is born with a massive defect at the umbilical ring, and a large portion of their abdominal contents, intestines, and sometimes even the liver, are sitting outside the body.
Wow.
Crucially, in an omphalocele, these organs are covered by a thin, translucent sac or membrane made of peritoneum and amnion.
Because they never truly left the protective space of the umbilical cord structure, they just failed to retract.
Exactly.
The source texts make a point to heavily contrast omphalocele with another condition that sounds very similar. Gastroschisis. How are they different?
They look somewhat similar at a superficial glance because both involve intestines outside the baby's body, but their embryologic origins, their anatomy, and their clinical implications are radically different.
Okay, let's break that down.
While an omphalocele is a failure of bowel return through the umbilical ring, leaving the bowel neatly covered by a membrane gastroschisis is a structural failure of the abdominal wall itself to close properly.
Oh, so the wall just has a hole.
Yes. Gastroschisis is a defect typically located just to the right of the umbilicus.
So in gastroschisis, the umbilical ring is normal, but there's a literal hole in the skin and muscle next to it, and the bowel just spills out through that hole.
Yes. And because it spills out through a defect rather than herniating into the cord, there is no covering membrane whatsoever in gastroschisis.
So the intestines are just exposed.
Completely exposed. The delicate bowel tissue is exposed directly to the harsh, slightly acidic amniotic fluid inside the womb for months during pregnancy.
That sounds incredibly damaging.
It is. This chronic exposure causes the intestinal wall to become thickened, matted, inflamed, and often covered in a fibrous peel by the time the baby is born.
That sounds significantly worse for the tissue itself. But the source mentions a massive caveat regarding the overall prognosis of these two conditions. Omphalocele is highly associated with other severe systemic issues, isn't it?
It is extremely highly associated. While the bowel itself might look healthier in an omphalocele because it was protected by the sac, the presence of an omphalocele is frequently a glaring red flag for underlying chromosomal abnormalities.
Like a kind.
Such as trisomy 13, which is Patau syndrome, or trisomy 18, Edwards syndrome, as well as severe, life-threatening congenital cardiac defects. The infant's overall survival often depends more on those associated heart and genetic conditions than on the abdominal defect itself.
And gastroschisis.
Gastroschisis, on the other hand, despite the bowel looking much worse at birth, is generally an isolated anatomical defect.
Oh.
It is rarely associated with chromosomal anomalies. Once the pediatric surgeon carefully reduces the inflamed bowel back into the abdomen and repairs the hole in the wall, the baby usually has an excellent long-term prognosis and goes on to live a completely normal life.
The distinction between the failure points umbilical ring versus abdominal wall is fascinating.
It changes everything.
Okay, so we've got the herniation, the twisting, and the abdominal wall defects. But our deep dive into the midgut isn't quite over, because there's one more very weird vestigial structure associated with the midgut that we need to unpack. The vitelline duct.
Ah, yes, the vitelline duct.
What's the story there?
Well, the midgut is unique among our three gut sections because it doesn't just float freely. Early on, it remains temporarily connected to the yolk sac, which is outside the embryo, providing early nutrients. This physical connection occurs right at the very apex of that primary intestinal loop via a narrow tube-like structure called the vitelline duct, or sometimes the omphalomesonteric duct.
So if I'm picturing the midgut loop as a hairpin, the vitelline duct is like a physical tether connecting the very curve of the hairpin to a balloon sitting outside the embryo.
That is a perfect visualization. Normally, as development progresses and the placenta takes over full nutrient delivery, this tether, the vitelline duct, completely obliterates.
It just goes away.
It shrinks, turns into a fibrous band, and disappears entirely by week 9. But occasionally, this obliteration process fails.
And leaves a remnant.
Yes. If a portion of the duct persists, it leaves a remnant attached to the small intestine. And the most common, clinically significant remnant is called a Meckel diverticulum.
Meckel diverticulum is an absolute classic medical board topic.
Oh, heavily tested.
The source texts outline exactly how this hidden remnant reveals itself. How does a Meckel diverticulum actually present in a patient?
The classic clinical presentation is a young child, typically around 2 years old, who suddenly develops painless lower GI bleeding.
Painless bleeding.
Right. They will have bright red or maroon-colored stool, but with no abdominal pain, no fever, and no signs of infection.
Which begs the obvious mechanical question, why is it bleeding at all? If it's just a leftover piece of an umbilical duct attached to the intestine, why does it spontaneously hemorrhage?
It bleeds because of a phenomenon called heterotopy, or ectopic tissue.
Okay, what does that mean?
The cells lining the inside of a Meckel diverticulum are often pluripotential. They get confused about what they're supposed to be. Most commonly, the diverticulum will contain ectopic gastric mucosa.
Wait, stomach tissue?
Exactly, meaning literal stomach tissue grows inside this tiny pouch in the lower intestine.
And stomach tissue's entire biological purpose is to pump out hydrochloric acid.
Exactly. This rogue stomach tissue secretes acid, just like it would if it were up in the actual stomach.
But it's in the intestine.
That's the problem. The stomach has a thick, specialized mucosal barrier to protect itself from its own acid. The surrounding intestinal lining of the ileum, where the Meckel diverticulum sits, does not have that barrier.
Just getting burned.
Right. It isn't built to handle raw acid. So the acid from the Meckel completely ulcerates the adjacent normal bowel mucosa, eroding into the highly vascular intestinal wall, causing profuse, painless bleeding into the GI tract.
That is mind-blowing. The child's intestine is bleeding because a stray patch of stomach tissue is hiding inside a vestigial umbilical cord remnant, burning a hole in the adjacent wall.
It's a bizarre chain of events.
That sounds like a diagnostic nightmare, too. If a kid comes in with painless bleeding, how do doctors even find a tiny pouch hiding yards deep into the small intestine? You can't reach it with a standard endoscopy or colonoscopy.
No, you can't. They rely on a brilliant piece of nuclear medicine imaging called a technetium 99-meter pertechnetate scan, universally referred to in hospitals as a Meckel scan.
I was reading about this in the sources, and I had to read it twice because the underlying logic is so clever.
It really is.
Our bodies have specific cellular affinities. The parietal cells in gastric mucosa, the cells that make acid, have a massive natural affinity for taking up the chemical pertechnetate from the bloodstream.
Right.
So the nuclear medicine doctors literally inject a safe radioactive tracer, technetium 99 meters, into the child's vein.
And then they just wait and watch with a gamma camera.
And what happens?
The radioactive tracer circulates and, as expected, heavily accumulates in the normal stomach and the upper abdomen, lighting it up on the scan.
Okay.
But crucially, it also gets greedily taken up by the ectopic gastric tissue hiding inside the Meckel diverticulum.
Oh, so you look at the scan and you see the stomach glowing in the upper left, but then you see this rogue glowing beacon lighting up in the lower right quadrant of the abdomen where no stomach tissue should ever be.
Exactly.
They literally use the rogue tissue's own physiological identity against it to find its hiding spot. That is amazing.
It is a stunning application of molecular biology to solve a gross anatomical mystery.
Okay, let's recap our journey. We have survived the severe molecular identity crisis of the foregut, balancing lungs and stomach.
Check.
We've navigated the chaotic migration, the 270-degree twisting, and the abdominal wall defects of the midgut.
Double check.
That brings us to the final stretch of the tube. What happens when the digestive waste reaches the end of the line? Let's talk about the hindgut.
We finally arrive at the hindgut territory. To define our boundaries, the hindgut picks up right where the midgut left off.
Right.
It extends from the distal 1/3 of the transverse colon down through the descending colon, the sigmoid colon, the rectum, and it stops at the upper anal canal.
And its arterial supply, completing our three-part map, is the inferior mesenteric artery, or AMA.
Exactly.
And the embryonic hindgut ends in a terminal chamber called the cloaca. Now, as someone who watches a lot of nature documentaries, cloaca always makes me think of birds, reptiles, and amphibians.
And you are exactly right to make that connection. The cloaca is a very primitive, evolutionarily conserved structure.
So we have one too, early on.
Early in human development, around weeks 4 through 6, the terminal end of the hindgut tube enters this singular common chamber.
Good.
The cloaca serves as a shared, combined exit point for both the primitive gastrointestinal tract and the developing urinary system. Everything empties into one room.
Which obviously presents a major anatomical problem for a human. We need those systems separated before birth. We cannot have the bladder and the rectum sharing the same exit.
Exactly. Just like the primitive foregut needed the tracheoesophageal septum to build a wall between the airway and the esophagus, the cloaca needs a septum to build a wall between the urinary tract and the GI tract.
So another wall has to be built.
Right. A specialized wedge of mesoderm called the urorectal septum begins to grow downward, plunging into the cloaca like a descending curtain, physically dividing the single chamber into two entirely separate rooms.
So it splits the space front to back.
Yes. The interior chamber, the front room, becomes the urogenital sinus, which will eventually develop into the bladder and the urethra. The posterior chamber, the back room, becomes the anorectal canal, which forms the rectum and the upper anal canal.
And the sources note that if this urorectal septum fails to descend completely, or if the membrane covering the cloaca fails to rupture properly, you get severe malformations, like an imperforate anus.
Right. Imperforate anus is a classic anorectal malformation. It happens when the delicate embryological steps of partitioning the cloaca and opening the anal canal to the outside world break down.
So the exit is closed.
A baby with an imperforate anus is born without a patent open anal opening. Often, the rectum ends in a blind pouch, or it forms an abnormal fistula connection to the urethra or the vagina.
That sounds complicated to fix.
It requires complex, staged surgical reconstruction to create a functional anal opening and preserve bowel continence.
It just highlights how many walls and septums have to be built perfectly for our bodies to function.
So true.
But let's assume the wall builds correctly. The anorectal canal leads down to the anal canal, which harbors its own very specific, highly tested embryologic boundary line.
Yes, the pectinate line. Also referred to in older texts as the dentate line because of its jagged, tooth-like appearance on endoscopy.
The pectinate line.
Okay, This line is the definitive developmental boundary of the GI tract, and it is a massive clinical landmark for surgeons and gastroenterologists.
Why is this one specific line so clinically important? I've seen it pop up in countless medical review questions.
It is important because the pectinate line marks the exact collision point of two entirely different germ layers.
Oh, they meet there?
Yes. Everything above the pectinate line is derived from endoderm, representing the very end of the original hindgut tube.
Okay.
But everything below the pectinate line is derived from ectoderm, specifically from an invagination of the outside skin of the embryo called the proctodium.
If I'm trying to visualize this, it's like a geopolitical border town. You have the inside of the digestive tube marching downward and the outside skin folding inward, and they meet exactly at this line.
That's exactly it.
And because they come from different embryologic countries, they follow completely different sets of rules.
The border town analogy is brilliant. Because the embryologic origins are different, endoderm versus ectoderm, literally every anatomical system changes the second you cross that line.
Everything changes.
The currency, the language, and the supply chains all flip. Above the pectinate line, the blood supply comes from the IMA, which is hindgut territory. The venous blood drains into the portal venous system, going to the liver, and the nerve innervation is strictly visceral autonomic.
And visceral innervation means you only feel generalized sensations like stretch or distension, not sharp, localized pain.
Precisely. The brain doesn't have a high-resolution map for visceral tissue.
Which explains a lot.
It's why internal hemorrhoids, which arise above the pectinate line, are generally completely painless, even if they are actively bleeding. The patient just notices blood, but no pain.
But the moment you step below the pectinate line into ectoderm territory, the rules change violently.
Very much so. Below the line, it is essentially modified skin. The blood supply completely changes. It comes from branches of the internal iliac artery system. The venous drainage bypasses the liver and goes straight to the systemic inferior vena cava.
And the nerves.
Most importantly, the innervation is somatic, supplied by the inferior rectal branches of the pudendal nerve.
And somatic innervation is the same high-resolution wiring that supplies your fingertips.
Yeah.
Meaning you feel highly localized, exquisitely sharp pain.
Exactly.
Which is exactly why external hemorrhoids or anal fissures, which occur below the line, are notoriously excruciating.
The patient feels every microscopic tear.
Wow.
The pectinate line is a masterclass in how an embryologic origin directly dictates adult anatomy, vascular flow, and even how a patient physically experiences pain in the clinic.
Okay, let's tie something back to the very beginning of our deep dive.
Yeah.
I want to bring back a critical concept from section 1.
Let's do it.
We talked extensively about the neural crest cells, those electricians that migrated into the early gut tube to form the enteric nervous system, the Auerbach and Meissner plexus.
Right, the wiring.
Do those neural crest cells have to travel all the way down here to the hindgut?
They do, and it is an incredibly arduous journey.
Tell me about it.
The neural crest cells start all the way up in the cranial and vagal regions of the embryo. They multiply and migrate caudally, wave after wave, surfing down the mesenchyme along the entire length of the developing gut tube.
So they have to go the whole way.
They travel through the foregut, through the massive spinning loops of the midgut, all the way down into the hindgut. The distal colon and the rectum are the absolute end of the line, the final frontier for these migrating cells.
If I'm picturing these cells migrating like an army marching for thousands of miles,
Yeah.
this raises a really important question. What happens if they run out of gas? What if the migration stalls or the signaling fails before they reach the very end of the hindgut?
That exact failure mechanism brings us to our final and perhaps most devastating clinical correlation in the sources: Hirschsprung disease.
Hirschsprung disease.
If the wave of neural crest cells fails to complete their migration, the distal colon and rectum are left completely devoid of enteric ganglia. They have no myenteric plexus and no submucosal textus.
To use our analogy, the walls are built, but there are no electricians. The drywall is up, but there are no wires in the house.
None whatsoever. The medical term for this is a ganglionosis.
A ganglionosis.
And just like we saw with achalasia in the esophagus, where the lack of inhibitory neurons meant the upper sphincter couldn't relax, the exact same physiological principle applies here.
The lower muscle gets stuck.
The lack of ganglia in the distal colon means the smooth muscle loses its ability to relax. Without those inhibitory signals, the smooth muscle of the aganglionic segment is stuck in a state of permanent high-tone contraction.
So it's essentially a functional obstruction. The tube is physically open, there's no tumor or physical blockage, but the muscle acts like a concrete wall because it refuses to open up and let a peristaltic wave pass through.
Yes. The normal, healthy, ganglionated bowel proximal to the defect tries desperately to push feces forward.
But it can't.
Every time the peristaltic wave hits this contracted ganglionic segment, it slams into a wall. The feces just back up,
Causing massive swelling.
Over days and weeks, the normal bowel behind the blockage dilates massively, creating a toxic megacolon.
That sounds horrible.
The classic clinical presentation is a newborn infant who fails to pass meconium, their very first dark, sticky stool, within the first 48 hours of life.
And then what?
This is rapidly followed by massive, tight abdominal distension and bilious vomiting as the entire GI tract backs up.
Let me pause you there because the sources detail the surgical approach to fixing this, and it is fascinating.
It's a very clever surgery.
Imagine you are the pediatric surgeon looking at this baby's x-ray. You see a massively dilated colon up high and a narrow, normal-looking rectum down low. Our intuition tells us that the swollen, ugly part is the diseased part, and the normal-looking part is healthy.
Right.
But the embryology tells us the exact opposite.
This is where surgical mastery intersects with embryological knowledge. The surgeon knows that the dilated, massively swollen colon is actually the healthy, properly innervated bowel that is just working overtime trying to push against a wall.
Wow.
The narrow, normal-looking segment at the bottom is the culprit. It is the diseased ganglionic portion that cannot relax.
So they have to remove it.
To cure the patient, the surgeon has to physically remove the ganglionic part and pull the healthy ganglionated bowel down and stitch it to the anus. It's called a pull-through procedure.
But how do they know where to cut? You can't see microscopic neural crest cells with the naked eye in an operating room. The outside of the colon looks exactly the same, whether it has ganglia or not.
They have to map the fetal migration in real time.
During the surgery.
The surgeon takes multiple small biopsies along the length of the colon and sends them immediately to the pathology lab for a freeze section analysis.
Okay, so the pathologist is looking at them right then.
The pathologist looks under the microscope, searching for the physical presence of ganglion cells in the myenteric plexus. They keep moving up the colon, taking biopsies, until the pathologist finally says, "Okay, I see ganglia here."
And that's the spot.
That marks the exact spot where the neural crest cells stopped migrating weeks before the baby was even born. That is the safe spot to cut.
They are literally tracing the halted footsteps of a fetal cell migration to perform a life-saving surgery. That is just incredible. The fact that an invisible cellular journey dictates a surgeon's scalpel decades later is mind-blowing.
It is the ultimate proof that the embryologic map is still the most vital document in the operating room.
So, what does this all mean? We have covered so much immense ground today.
We really have.
We started with a single straight endodermal tube and a folding 3-week-old embryo. We watched it undergo a molecular tug-of-war to split into breathing lungs and an acid-secreting stomach.
A huge transformation.
We watched the midgut literally erupt out of the body cavity, twist a precise 270 degrees counterclockwise around a single artery, and pack itself intricately back in.
The origami suitcase.
Exactly. And we watched a microscopic wave of neural crest cells surf down the entire length of that chaotic tube to wire the whole system up, dictating motility from the throat to the pelvis.
If we connect all of this to the bigger picture, what we've really uncovered today is that human adult anatomy isn't just an exercise in arbitrary memorization for medical students.
Right, there's a logic to it.
It is a highly logical, deeply coherent story, but only if you know how to read the embryologic chapters first.
That makes perfect sense.
The terrifying diseases we struggle with in the clinic, the achalasias locking up the esophagus, the fistulas flooding the lungs, the catastrophic ischemic malrotations, the megacolons of Hirschsprungs, they aren't random, unpredictable glitches in a machine.
No, they're traceable.
They are specific, traceable echoes of a developmental program that hesitated, misfired, or stalled out weeks before we were even born.
And that leads me to one final, completely mind-bending thought that I found buried in the depths of our source text.
Oh, let's hear it.
We talked a lot today about the steadfast rules of the gut. Celiac artery equals foregut. Endoderm equals the gut tube lining. We talked extensively about how the massive solid organs, the liver, the gallbladder, the entire pancreas, butted directly off that endodermal tube, sharing its origins.
We established the strict epithelial mesenchymal signaling rules, yes. The gut builds its neighbors.
Right. But then you look at the spleen.
Ah, the spleen.
The spleen is a fist-sized organ nestled right up against the greater curvature of the stomach in the upper left quadrant of the abdomen.
Yes, it is.
It gets its massive blood supply from the splenic artery, which is one of the three main branches of the celiac trunk.
Correct.
By all our rules, physical proximity to the stomach and sharing the exact same foregut arterial supply, the spleen should absolutely be a foregut derivative. It should be an endodermal organ just like the liver or pancreas, but it's not.
It is the great anatomical exception.
The Master Guide explicitly points this out as a major exam trap because it defies visual logic. Despite sitting right next to the stomach, and despite stealing its blood supply from the foregut celiac trunk, the spleen is entirely derived from the mesoderm.
Completely different origin.
It develops completely independently from mesenchymal tissue condensing within the dorsal mesogastrium, the mesentery behind the stomach. It has absolutely no endodermal component whatsoever. It is not part of the gut tube.
It is a hematopoietic and lymphoid organ that essentially hitchhikes on the gut's blood supply.
Exactly. So next time you look at a standard anatomy chart or picture your own organs inside you, realize that physical proximity is a complete illusion.
That's a great way to think about it.
Organs sitting right next to each other, touching each other in your body, have entirely different embryologic passports and molecular ancestors. Your body isn't just a static machine of parts. It is a living, breathing fossil record of your first 10 weeks of existence.
A beautiful and perfectly accurate way to put it.
Thank you for joining us on this incredibly intricate deep dive into the origins of you. As always, keep questioning the map, keep looking for the cellular history behind the anatomy, and we warmly invite you to submit your next stack of sources for us to explore. We will see you next time.